Welcome to the Dep Dive. Today we're zeroing in on drug-induced lupus, DIL for short. Basically, it's when you get lupus-like symptoms, but they're triggered by certain medications.
Exactly. And the really important thing is that it usually clears up once you stop taking that particular medication.
So it's not quite the same as SLE, systemic lupus, or erythematosus.
Right. There's overlap, sure, but DIL tends to be, well, a bit milder. And things like serious kidney or nervous system problems are much less common than in SLE. The defining feature really is that it should resolve when the drug is withdrawn.
Okay, makes sense. So what actually kicks off this reaction? The notes mention an immune response to specific drugs. Can you give us some of the main culprits?
Yeah, absolutely. Certain meds are definitely known triggers. We often see it with drugs like Hydralazine, Procainamide. Isoniazid is another common one. There are others, of course, but those are probably the highest yield ones to know.
Hydralazine, Procainamide, Isoniazid. Got it.
And there's some thinking that drugs like Hydralazine might affect DNA methylation, which could be part of how they trigger the immune system. Interesting stuff.
Huh. So if you're on one of those drugs, does that automatically mean you're at high risk? Or are some people more prone to it?
Well, taking the drug is the primary risk factor, obviously, but it's not guaranteed you'll get DIL. There does seem to be a role for genetics. Some people might just be more genetically susceptible, but we're still figuring out the details there.
Right. Okay. So the drug sets something off in the immune system. Can you walk us through what's actually happening, the pathophysiology?
Sure. So these specific drugs seem to initiate an immune response where the body starts making autoantibodies. These are antibodies that, well, they mistakenly attack the body's own cells and tissues.
Like friendly fire from the immune system.
Kind of, yeah. These autoantibodies can form clumps, immune complexes, which then get deposited in various tissues. And that deposition causes inflammation and damage, leading to the symptoms, which looked a lot like lupus. It's like the drug confuses the immune system.
Okay, that clicks. Now, if someone comes in with these symptoms, fatigue, joint pain, maybe a rash, what else needs to be on the differential diagnosis?
Good question. You absolutely have to consider SLE itself, naturally. But also other autoimmune diseases need to be ruled out. And even infections, sometimes they can present in similar ways.
Right. So how common is DIL actually? Is this something you'd see frequently?
It's considered relatively rare, definitely less common than SLE. The exact incidence, it varies quite a bit depending on which drug you're looking at and the population being studied.
Okay. Let's talk symptoms then. What does a typical presentation look like?
Well, as you said, fatigue, joint pain, arthralgia, muscle pain, myalgia are very common. Rashes, particularly photosensitive ones, fever. It really can mirror SLE quite closely.
Any specific patterns?
Yeah, arthralgia and myalgia are probably the most frequent. Skin manifestations are common too, and sometimes pulmonary symptoms like pleurisy. Organ involvement like kidney or heart issues can happen, but it's less typical than in SLE. And crucially, remember, symptoms should get better after stopping the medication.
Gotcha. And the blood tests. What are the key findings there? That seems important for distinguishing it.
Hugely important. So the ANA, anti-nuclear antibody, is almost always positive, like 100% positive in DIL.
Wow.
But, and this is a key difference, the anti-double-stranded DNA antibody, anti-dsDNA, which is quite specific for SLE, is usually negative in DIL.
That's a big clue.
It is. And another thing we often see are anti-histone antibodies. They're positive in maybe 80–90% of DIL cases. Much more common in DIL than classic SLE.
Antihistone positive, dsDNA negative. Okay.
Yeah. And things like anti-Ro or anti-Smith antibodies, they're less common in DIL, maybe only around 5% positive.
So the investigation strategy involves those blood tests, ANA, anti-dsDNA, antihistone checking for organ involvement if needed, and really digging into that medication history.
Absolutely critical. You need to correlate the timing. When did the drug start? When did the symptoms appear? That timeline is key.
Okay. And how do we manage it here in the UK?
Management is usually quite straightforward, thankfully. Step 1, stop the offending drug. That's paramount.
Right.
Then for the symptoms, often NSAIDs for joint pain and inflammation are enough. Just general supportive care. If things are more severe or symptoms hang around for a while after stopping the drug, then corticosteroids might be considered to dampen down the immune response.
And what's the outlook usually? The prognosis?
Generally, it's very good.
Yeah?
Excellent, really. Once you stop the causative medication, the symptoms almost always resolve completely.
That's reassuring.
It is. It's
Yeah.
rare, but just occasionally it might unmask or evolve into a chronic autoimmune condition like SLE later on, but that's definitely not the norm.
Okay. Any complications to worry about?
Complications themselves are rare, especially if it's caught early and the drug is stopped. The main risk would be organ damage if it goes unrecognized for too long and the drug exposure continues. Long-term issues are really only a concern in those very rare cases that might transition towards SLE.
This has been super helpful, really clarifying. Now, remembering those key drugs, the notes mentioned a mnemonic.
Yes. A simple one is just like HIPH for hydralazine, I for Isoniazid, P for Procainamide. Helps lock in the main ones.
HIP, nice and easy. Okay, let's try a quick question then. Say you have a patient on long-term Procainamide who develops joint pain and a classic malar rash. What's your top diagnosis and your first move?
Given that history, drug-induced lupus is the most likely diagnosis, and the immediate first step is to discontinue the Procainamide.
Perfect. And a final memory pearl.
Just remember, if you see lupus symptoms presenting, but that anti-dsDNA test comes back negative, definitely think drug. Check the medication list.
Great tip. So the big takeaway here is that DIL is tied to meds, looks like lupus, but usually isn't chronic. Stop the drug, symptoms resolve.
That's the essence of it. Always, always review the medications when someone presents with potential lupus symptoms.
Fantastic. And for everyone listening and revising for the MSRA, don't forget to check out pastthemsra.com.
And also freemsra.com for more great resources.
Thanks again for this deep dive.